Hello, everyone. I'd like to welcome you all to the second semester lecture series. And I'd like to introduce our today's lecturer, Dr. Soyoung Gang. And some of you may have met her from the first semester lecture series. Dr. Kang is currently a professor in the Department of Nuclear Medicine, Ewha Women's University Seoul Hospital. And Dr. Kang has accumulated outstanding achievements in the research of oncology and nuclear medicine. So today, Dr. Kang will deliver us a lecture regarding correlative imaging in gynecologic cancers. So she will show us image-based anatomy and role of FDG PET in nuclear medicine in gynecologic cancers. So please welcome Dr. Soyoung Kang.
Hello?
Yes, we can hear you.
Hello, can you hear me?
Yes, we can hear you.
Yeah, okay. Hello, I'm Soyoung Gang, nuclear medicine physician. Now I'm working at Ewha Women's University Medical Center. Today I'm talking about gynecology, actually gynecologic oncology. Let's start. Gynecologic cancer is any cancer that starts in women's reproductive organs. Cancer is always named for the part of the body where it starts. Gynecologic cancers begin in different places within a woman's pelvis, which is the area below the stomach and in between the hip bones. Its gynecologic cancer is unique with different signs and symptoms and different risk factors and different prevention strategies. All women are at risk for gynecologic cancers and risk increases with age. When gynecologic cancers are found early, treatment is more effective, such as it's the same for all cancers. So today at this time, we are going to be dealing with three major cancers. Actually, there are 5 main types of gynecologic cancers: cervical, ovarian, uterine, vagina, and vulva. And the 6th type of gynecologic cancer is the very rare fallopian tube cancer. So today, we are dealing with the major 3 cancers: cervical, ovarian, and uterine cancers. So at first is cervical cancer. Cervical cancer is the 4th most common cancer among women globally, with an estimated 604,000 new cases and 342,000 deaths in 2020. High-risk subtypes of the human papillomavirus cause almost all cervix cancers. 2 human papillomavirus types, 16 and 18, are responsible for nearly 50% of high-grade cervical cancers. Prevention and screening will reduce mortality rate. Of all the gynecologic cancers, only cervical cancer has a screening test that can find this cancer early when treatment can be most effective. There are several risk factors. Major risk factor is infection of HPV oncogene types, and the other risk factors are trachomonitis infection, HIV, HSV, or contraceptive. According to According to Globacon in 2020, there were 604,000 new cases of cervical cancer. It is 6.5% of all cancers in females. And also there were 341,000 deaths of cervical cancer. It is 7.7% of death causes in female. Cervical cancer remains the most common cause of death in the less than 35-year-old female population, despite the development of screening and vaccine, and remains the leading cause of cancer death in women in the majority of Africa and Southeastern Asia. Excuse me, can you hear me?
Yes.
Oh, sorry about that. I didn't know that. Okay. Okay. So can you see my slides?
Yes.
Yes.
Okay. Yeah. Yeah. Sorry about about that situation. Yeah. Let's start. So, yeah. Maybe you can you see this slide? Yeah. Actually, I already explained of the incidence and the number of deaths in cervical cancer in 2020. So yeah, next, this is historical subtypes of cervical cancer. So here is the updated classification of tumors of the cervix as per the WHO classification of tumors of female. So maybe you know the major type of cervical cancer is epithelial tumor. Of epithelial tumors, squamous cell carcinoma consists of 85% of all cervical cancer. And the others are the glandular tumors such as adenocarcinoma, 10%. And also there is a small portion of neuroendocrine tumors, also mesenchymal tumors and the others. So it is widely accepted that invasive squamous cell carcinoma of the cervix, which is the commonest histological type, is preceded by a pre-invasive stage of the disease where the abnormal cells are confined to the epithelium. So this stage of non-invasive disease is known as cervical intraepithelial neoplasia, CIN, and is directly related to the processes of infection and integration of HPV. So here the mild dysplasia corresponds to CIN1 and moderate dysplasia corresponds to CIN2 and severe dysplasia means CIN3. The development of CIN involves progression from early changes CIN1 involving the deeper layers of the epithelium to full thickness involvement at its most severe, equating to carcinoma in situ. So there are two main staging systems for gynecological cancers used by clinicians for evaluating prognosis and choosing among treatment options. The one is to tumor node metastasis, TNM system, and the other one is the International Federation of Obstetrics and Gynecology system, FIGO system. So the first one is the updated FIGO staging system for cervical cancer. So yeah, in the stage 1, the cervical carcinoma can be diagnosed only with microscopy. Actually, it is a 1A. Actually, in the stage 1, carcinoma is strictly confined to the cervix. And the detailed staging of stage 1 depends on the tumor size and on the invasion depth. And stage 2 carcinoma invades beyond the uterus, but has not extended onto the lower third of the vagina or to the pelvic wall. Stage 3 carcinoma involves the lower third of the vagina and or extends to the pelvic wall and or causes hydronephrosis or non-functioning kidney or involves pelvic and para-aortic lymph nodes. And the stage 4 carcinoma has extended beyond the pelvic cavity. So here is the TNM system, staging system for cervical cancer. The TNM system is produced by the American Joint Committee on Cancer, AJCC, and the International Union Against Cancer, UICC. The AJCC liaises with both the FIGO and the UICC in producing its TNM staging. As a result of this collaboration, the AJCC TNM staging aligns with FIGO staging. The only difference being that the AJCC TNM staging includes granular details of each staging component. Also, there is no regularity to the frequency of staging updates by FIGO, whereas AJCC staging updates have been published on average every 5 to 6 years for the last decades. So here you can compare the TNM staging with the FIGO staging. It is a very similar staging system because their collaboration. And in end staging means the regional lymph node metastasis. So it depends on the lymph node size and the location. So just in end staging, the lymph nodes means invasion to para-aortic lymph nodes. If the lymph nodes invade beyond para-aortic lymph nodes, and then the staging for into end staging. So let's find out the role of FDsPAT-CT in cervical cancer. Actually, FDsPAT-CT is very useful modality evaluating all kind of cancer in staging and treatment response and disease recurrence and the prognosis. In the cervical cancer, also is the similar role of FDsPAT-CT. So we can evaluate the staging and treatment response. And also in the cervical cancer, the main treatment option is the radiotherapy. So sometimes it is useful, FDsPAT-CT is useful for targeting radiotherapy planning lesion. So this is the case showing the role of PET-CT in the initial staging of cervical cancer. It is a 57-year-old woman with clinical stage 1B cervical cancer. In the SASTAR fusion FDsPAT-CT, you can hear hypometabolic mass in the cervix suggesting cervical cancer. The large region is probably uterus. And there is a suspicious hypometabolic region between uterus posterior wall and the cervical mass here. So it means there are high probability of the invasion of cervical cancer into the posterior wall of urinary bladder. And also in the contrast enhanced CT imagery show loss of fat brain between cervix and the rectum. So that means infiltration of rectal wall. So after opacity, at first the clinical stage 1B, but after opacity, the disease was upstage to stage 4A. So which altered management. Yeah, second case is similar with the previous one. It is staging for cervical cancer. Here is a hypometabolic mass in the uterine cervix area, suggesting cervical cancer. And the urinary bladder here. Maybe here is very hypometabolic regions in between urinary bladder and the primary cervical cancer. So this case has also high probability of invasion of tumor to the urinary bladder posterior wall. And also there are multiple hypometabolic lymph nodes in the bilateral pelvic wall and also left inguinal area. So the patient has got chemo sensitization before surgery. Next case is shows the role of apopacity in treatment response evaluation. This is a case of 60-year-old woman with inoperable stage 4B cervical carcinoma with multiple lymph node metastasis. Here is initial apopacity. So yeah, hypometabolic mass here, probably cervical cancer. And also there are suspicious hypometabolic regions in around the bowel area, suggesting peritoneal carcinomatosis. So after chemo radiation in the phallopacity, there are hypometabolic new regions in the liver, suggesting metastasis, and also lungs, suggesting metastasis, and also multiple hypometabolic lymph node in the para-aortic chain. So yeah, this is the case, it shows the failure of treatment. Next example is the role of apopacity in the radiation therapy planning. The patient is a 65-year-old woman with locally advanced cervical cancer, stage 3B, with endometrial involvement and pelvic and para-aortic lymph node adenopathy. Apopacity images show gross tumor volume with the red border here, delineating hypometabolic mass with the vaginal and posterior bladder here. And the clinical tumor volume with the green border here, including bilateral iliac chains and aortocaval lymph nodes. Gross tumor volume GTV was considered extension of tumor, taking into account macroscopic disease at clinical examination and visible tumor on PET-CT images. Accurate target clinical tumor volume, CTV, is vital for the definitive treatment of cervical cancer with intensity moderated radiotherapy. So this patient was treated with a 45-grade dose of radiation therapy to pelvis, inguinal, and para-aortic lymph nodes with concurrent chemotherapy. Next case is showing the role of apopacity in the response evaluation. A 47-year-old woman with stage 2B squamous cervical carcinoma with bladder involvement. Here. Patient received total dose of 45 centigrade. So initial PET-CT images showed large hypometabolic masses in the pelvic cavity. But after radiation therapy, the PET-CT images show the interval partial treatment response. The hypometabolic cervical mass has decreased in size and FDC activity. Active max changed to 8.3 from 11.2. This is another case shows the role of the FDC PET-CT in the response evaluation. So this is the patient. The patient is an 82-year-old woman with invasive, poorly differentiated carcinoma with feature of squamous cell carcinoma. So in the initial PET-CT, yeah, actually there is no main cervical cancer. Anyway, here is endometrial cavity is fluid filled, and there are hypometabolic lesions, probably invading lower uterine segment, and also is another hypometabolic lesions in the left pelvic cavity. And after 3 cycles of etoposide and carboplatin interval, there was one chemotherapy. The PET-CT image shows no abnormal hypometabolic lesions in pelvic cavity, suggesting viable residual tumors. So this case shows the complete metabolic response after therapy. Here is the mild hypometabolic lesions in the abdominal wall, suggesting post-surgery changes. Next, I talking about the other tracer evaluating cervical cancer. Fibroblast activation, protein inhibitor, FAPI PET-CT. Actually, it is very famous and interesting tracer evaluating all kind of cancers. So FAPI PET-CT is new tool in the diagnostic workup of cancer. So here, maximum intensity projections of gallium FAPI PET-CT in patient reflecting 15 different histologically proven tumor entities. So although there are variety of physiological uptake in the mammary glands and bone degeneration in the FAPI PET-CT, but you can see here very high discernible lesions in evaluating cancer, primary cancer, and also metastatic lesions with a FAPI PET-CT. So this is a case of the primary cervical cancer with the FAPI and also FDC PET-CT. A 59-year-old patient was hospitalized due to vaginal bleeding for more than 1 month, and the cervical biopsy demonstrated differentiated squamous cell carcinoma. So she was then included in the clinical trial of FDC and FAPI PET examination for further detection. FAPI PET MRI scans show the irregularly thickened cervix, and also there is the region is a restricted diffusion or diffusion-weighted imaging. And in the FAPI PET, the region showed increased FAPI uptake here. And the FD capacity also showed the increased hypermetabolism in the uterine cervix. So FAPI capacity showed the similar detectionability or sensitivity of cervical cancer compared to the FD-SPAC. The other cases, this is cases in the detection of metastatic regions of cervical cancer using FAPI and FD capacity. 2 patients with cervical cancer were performed FDC and FAPI PET scans to detect metastasis. In patient 1, the MIP image of FAPI PET found 47 lymph nodes with high uptake in the left suprapubic fossa and the mediastinum and parietal diaphragm area, retroperitoneum, iliac chains. So yeah, it is highly detective of metastatic lesions. However, if this PET image detected 23 lesions in the left suprapubic fossa and the mediastinum, and also retroperitoneal space and iliac chains. So it's a little bit less detective compared to the FAPI PET. And in patient 2, FAPI images clearly showed 27 lymph nodes in the left suprapubic fossa and diaphragmatic area and retroperitoneum, iliac vessels, and left inguinal area. However, only 14 lymph nodes were demonstrated in the left suprapubic fossa and retroperitoneum and iliac area on FD-SPAC images. So in this study, they showed that high sensitivity of the FAPI capacity in the detection of metastatic lesions compared to the FD capacity. And this graph shows the relationship between FAPI SUV max and volume of uterus and age and FDC uptake. The reason why of this comparison, because there are variety of physiological uptake in the FAPI capacity in the previous slide. Here, yeah. Actually, it is very. Actually, it is one of problematic regions in the FAPI capacity evaluating cancer regions, especially in the uterus. It showed very high uptake in the endometrial cavity. So they compared in FAPI SUV max with volume of uterus, also age and FDG uptake. So the urine uptake of FAPI were positively correlated with the size of uterus, and it is negatively correlated with age. So that means the FAPI uptake in the uterus with is highly related to the activation state of endometrial cells. And there was no statistical correlation between FDC and FAPI uptake. And in the cervical cancer patient, the SUV max was significantly higher than that in the normal cervix. So it means although there are variety of physiological uptake in the uterus, however, FAPI capacity can differentiate cancer uptake from the physiological uptake in the uterus. Okay, this is the end of the cervical cancer. Now let's move on uterine cancer. Uterine cancer is sixth most common female malignancy worldwide. It is a general term that describes cancers of uterus. Uterine cancer can refer to either endometrial cancer, uterine sarcoma, or other rare forms of cancer that can arise in uterus. But people often treat the terms endometrial cancer, that uterine cancer, and the same. That's because endometrial cancers are much more common than other cancers that can form in uterus. So endometrial cancer develops in the endometrium, the inner lining of uterus, and uterine sarcoma develops in the myometrium, the muscle wall of uterus. So the major risk factor of endocrine cancer is obesity. And the other risk factors are genetic disorder, age, diet, family history, menstrual and reproductive history, radiation history, and estrogen replacement therapy or use of tamoxifen. So this graph shows the association of obesity with cancer. A higher body mass index is associated with an increased risk of endometrial cancer. Among many cancers, endometrial cancer is the most strongly associated with obesity. According to Globacon, there were 415,000 new cases of uterine cancers. It's 4.5% of all female malignancies. And also there are 97,000 deaths in the uterine cancers. So it is 13th place of cause of death in females. This is the histological types of uterine cancers. The major histological type of uterine cancer is endometrial carcinoma. Including adenocarcinoma variants, and other types. And the other histological types are mucinous adenocarcinoma and serous or clear cell and mixed carcinoma. And carcinosarcoma is actually type of mesenchymal tumor. However, in which both the epithelial and mesenchymal components. These days, these cancers are considered metaplastic carcinomas and are treated as aggressive carcinomas. So the staging systems of endometrial cancer, it is similar with the cervical cancer. The TNM system and FIGO system shows a very similar staging state. So in T1 staging, FIGO system 1 means tumor confined to corpus uteri, including endocervical. Maybe it is type 4. Excuse me, just it's my mistake. Yeah, including endocervical glandular involvement. And TNM staging P2 and FIGO staging 2 means connective tissue not extending beyond uterus. In the stage 3, the tumor involves serosa, adnexa, vagina, and parametrium. In stage 4, tumor invading the bladder mucosa, bowel mucosa, and bone. the end staging is also similar with the cervical cancer staging. So end staging is the regional lymph node system, and it depends on size and location of lymph node. And the end stage lymph node is confined to the para-artery lymph nodes, and if the lymph node invade beyond the para-artery lymph node, and then the staging fall into M staging. And M staging means the patient has distant metastasis. So yeah, the role of FT-spasticity in the uterine cancer is also similar with the role of the cervical cancer. FT-spasticity is useful for evaluating staging and treatment response, and also differential diagnosis between sarcomas, uterine sarcomas, and leiomyomas. This is the data from the systematic review and meta-analysis evaluating a diagnostic value of FT-spasticity in the endometrial cancer. So the first row, this is the shows the FT-spasticity has moderate sensitivity and high specificity 0.94 in the detection of lymph node metastasis. So that means FT-spasticity has moderate sensitivity and high specificity in the detection of metastatic lymph node from endometrial cancer. And second row, this data in the detection of endometrial cancer recurrence. So FT-spasticity has high sensitivity of 0.95 and high specificity and 0.91. So demonstrating excellent diagnostic performance in the detection of endometrial cancer recurrence with FT-spasticity. So this is the case of the role of FT-spasticity in the clinical situation. First, it is for staging. The patient found the mass lesion in the uterus. So for staging and diagnosis, performed FT-spasticity. Here is a hypometabolic mass in the uterine cavity and highly suspicious for malignant lesion. So, but there was no abnormal hypometabolic lymph node suggesting metastasis in pelvic cavity and para-aortic area. And also there are no abnormal hypometabolic lesions suggesting distant metastasis here. So the patient got surgery. The pathologic finding was endometrial carcinoma. It is very common type of endometrial cancer. And also, as we found out in the PET-CT, there was no metastatic lymph nodes. So the patient diagnosis with pathologic staging T1A and 0. Yeah, another case is for the role of staging of FT-spasticity in the endometrial cancer. This patient also performed FT-spasticity for evaluating the mass lesion in the uterus. So there is a hypometabolic mass in the uterine cavity, suggesting malignant mass. And yeah, there was no abnormal hypometabolic lymph node in the pelvic cavity and para-aortic area. And also there was no evidence of distant metastasis. So she has got surgery. The pathologic finding is undifferentiated carcinoma. So yeah, it's a little bit aggressive type of cancer compared with the previous one. And the pathologic staging is T1B, and the end staging was negative. So the final staging of the patient T1B and 0. And next case is uterine leiomyomas. Actually, uterine leiomyomas is very common benign tumors in the uterus. However, sometimes it is confused with the same mesenchymal tumors, sarcoma. So yeah, sometimes in the clinicians performed FCSPACity to rule out malignant sarcoma. So this patient has a metastastic lesion in the uterus, and in the FCSPACity, the lesion showed just by the hypometabolic activities is really similar to uterus. So we can conclude the highly probable of leiomyomas. And the pathology finding was also leiomyomas. This is the other cases suspicious myomas in the uterus. In the MRI, there are 2 mass lesions in the uterus. So it is suggestive leiomyomas in uterus. However, the clinician wanted to rule out uterine sarcomas, so performed FCSPACity. So the 2 metastastic lesions are seen in the uterus, and they have hypometabolic activity. The small region is SU max was 5.1, and the more large region SUV max was 7. So it is a little bit confused SUV max evaluating leiomyomas from uterine sarcomas because the cutoff value is a little bit high. But actually, the MRI finding suggested the high probability of leiomyoma. We can conclude it probably leiomyomas with degeneration. As you know, if the leiomyomas are degenerated, there are several inflammatory changes in the myomas. So we can see highly metabolic activities in the myomas. And the pathologic finding of this patient, yeah, leiomyomas with degeneration. Yeah, this case is another metastastic lesion in the uterus. This patient is a hypermetabolic mass in uterus, single lesion. Actually, at first the clinician thought it probability of myomas, but FCSPACity showed a high average uptake of the tumor. And the pathology finding was carcinosarcoma. Actually, in the previous slide, I told you carcinosarcoma is a kind of mesenchymal tumor, but these days it is treated as a highly aggressive carcinoma. So this patient diagnosis with carcinosarcoma, and endometrioid carcinoma portion was 60%, and stromal sarcoma myxoid variant percent 40%. This is the data from the system review and meta-analysis evaluating differential diagnosis role of FCSPACity in the between leiomyomas and sarcomas. So first plot of here, it shows that the moderate sensitivity of 0.88 and the moderate specificity 0.83 in the for differentiating between uterine leiomyomas and uterine sarcomas. And also the Fagan monogram data indicated that when the pretest probability was set at 12%, a negative result for uterine sarcomas decreased the post-test probability up to 2%. And at a pretest probability of 50%, a positive result for uterine sarcomas increased the post-test probability up to 84%. So yeah, this data suggests the very important, useful roles of FDSPACity, differentiating between uterine sarcomas and leiomyomas. This is another case of uterine cancers with hyper and heterogeneously metabolic activity. So can you guess the pathology finding of this tumor? Yeah, it's really highly metabolic activity and the mass size is large. So at first we thought it could be sarcoma, uterine sarcoma, and the pathology finding it was a carcinosarcoma. Yeah. It's a high-grade endometrial stromal sarcoma, 95%, and carcinoma is 5%. And this case is another case, has large mass in the uterus and invasion to vagina here. So actually, we thought also this case is probability sarcomatous region in the uterus because very highly metabolic, highly hypermetabolic mass with a necrotic change in the center. However, the pathology finding was GIST, gastrointestinal stromal tumor. So it is very rare and interesting cases in the uterus and vagina. Yeah, next is as like cervical cancer. I'd like to show the FAPI PET imaging and evaluating of uterine cancer. So this is a postmenopausal woman who was examined because of elevated tumor markers. Gallium FAPI PET showed a diffuse and elevated uptake in the uterus here. And after FDSPACity, images also displays the large uterus with size and increased uptake. So compared to the cervical cancer, in the uterine cancer, the FDS uptake is more high compared to the FAPI uptake in the endometrial cancer here. The pathology finding was endometrial adenocarcinoma. This is another case evaluating uterine mass using FAPI PET-CT. Actually, this patient has gastric carcinoma patient. FAPI PET was performed in the gastric carcinoma patient. So it showed a high FAPI uptake in the stomach area and also multiple uptake regions in the peritoneum suggesting metastasis. And also there are large mass-like region with increased FAPI uptake in the uterus. So yeah, what do you think about that mass? It is metastasis, but the uptake pattern is very different with the primary gastric tumor. It's a more high uptake in the uterine mass. Pathology finding is uterine fibroid. Fibroid means leiomyoma, yeah. So it was uterine myomas. So it probably these rheomyomas have degeneration. So yeah, degenerative rheomyomas also have high FAPI uptake as well as FDG uptake. And second case, in case is the patient is a 53-year-old woman with chronic hepatitis. So you can see here diffuse uptake in liver in the FAPI path. That means FAPI is, yeah, as you know, fibroblast activating protein inhibitor. So diffuse fibrosis in liver can be detected in the FAPI passivity. And also in the uterus, there is diffuse uptake around IUD here. So it probably inflammatory change or other something benign changes around IUD. The patient, there was no malignant lesion. So yeah, that means in the previous slide, I showed a variety of physiologic uptake or P4s of FAPI passivity. And also there are, you can see, you can inform the uterine myomas also have increased FAPI uptake and also some inflammatory changes and fibrosis. Yeah, okay, so the end of the uterine cancer here. Now let's move on. Ovarian cancer. As today it's a final cancer. Ovarian cancer is seventh most common diagnosed cancer among women in the world. Ovarian cancer is not single disease and can be subdivided into at least 5 different histological types that have different identifiable risk factors, cells of origins and molecular compositions and clinical features and treatments. A woman is at an increased risk if she has a family history of ovarian cancer, especially first-degree relative, and also inherited risk, BRCA1 or BRCA2 gene mutations, and endometriosis, and hormone therapy, and obesity. According to Globocon 22, there was 313,000 new cases of ovarian cancer. It's 3.4% of all kind of female malignancies. And also there are 207,000 deaths of ovarian cancer. It's the eighth place of the cancer deaths in females. So this is the FIGO stage of ovarian cancer. Stage 1 ovarian cancer is confined to the ovaries. Stage 2 ovarian cancers has metastasized to near locations with a pelvic cavity, such as fallopian tubes or bladder. The stage 3 ovarian cancer has metastasized to the retroperitoneal lymph nodes or outside the pelvic cavity. Stage 4 ovarian cancer involves the malignant cells in pleural effusion and metastasis to distant sites. So yeah, TNM staging is similar with the FIGO staging. So this figure shows the clinical ovarian staging, easily understandable. And so here, figure A means stage 1 ovarian cancer. So cancer confined to the ovaries, and in the figure 2, cancer cells invade to near locations within pelvic cavity, fallopian tubes. And in the stage C, ovarian cancer invades to the outside of pelvic cavity, such as retroperitoneal lymph nodes, and also the spread into the vagina. And stages 4 ovarian cancers has spread to other organs such as lungs, pleura, and liver. So here is a histologic classification of ovarian cancers. In the previous slide, I told you ovarian cancer is not a single cancer. It can be subdivided into several different histological types depending on their cell origins. So yeah, there are a variety of the histological subtypes of ovarian cancer. Epithelial tumor is a major type, and the mesenchymal tumors and the mixed types and sex-cold stromal tumors, and also germ cell tumors, yeah, the others. So the major type of epithelial tumors, so yeah, today, yeah, we are focusing the epithelial tumors of ovarian cancers. Here are the major subtypes of ovarian cancers. Yeah. So figure A shows the high-grade serous carcinoma is the major ovarian cancer and has poor prognosis. This high-grade serous carcinoma is characterized by severe nuclear atypia and high nuclear to cytoplasm ratio, also abundant mitosis. And figure B is serous tuber intraepithelial carcinoma. And figure C is low-grade serous carcinoma. Actually, the serous carcinoma has papillary architecture and also mild nuclear atypia. And figure D is clear cell carcinoma. As the name clear, it is characterized by large atypical tumor cells with frequent clearing of the cytoplasm and also the stromal hyalinization. And figure E, endometrioid carcinoma, adenocarcinoma. And figure F is mucinous adenocarcinoma. So you can see here mucin filled tumor cells. Yeah, this is another details of the major subtypes of ovarian cancer. So yeah, high-grade serous carcinoma consists of 70% or ovarian carcinomas, and the other clear cell carcinoma consists of 10%, and endometrioid carcinoma also consists of 10%. And this table shows the characteristics of ovarian cancer by histology and genomic characteristics and active therapies. Yeah, high-grade serous carcinoma and high-grade endometrioid carcinoma usually can present peritoneal carcinomatosis and ascites and pelvic mass. So usually these cancers are typically advanced stage at presentation. And low-grade serous carcinoma usually present in young patients, so it can be early or late stage at presentation. And the low-grade endometrioid carcinoma can be associated with endometriosis, of course. And clear cell carcinoma can present with parenchymal metastasis in the liver and the lungs. It can be associated with hypercoagulability and hypercalcemia. And finally, mucinous carcinoma can be present in younger patients, and it's typically early stage at presentation. So yeah, the role of FLIS-Passity in ovarian cancer is similar with other gynecological cancers. So it is useful in the staging and the treatment response evaluation and evaluation of disease recurrence. So first case is ovarian cancer patient stage 3C. So here is a bilateral cystic mass with hypometabolic portion in the pelvic cavity, and also multiple hypometabolic lymph node in the para-aortic chain and iliac area, and also both supraclavicular fossa. So yeah, the pathologic finding was serous adenocarcinoma, high grade. Yeah. So the patient is stage 4. So she has got surgery and concurrent chemoradiotherapy. Second case is also ovarian cancer with the large metastatic lesions. So yeah, in the pelvic cavity, primary tumors here, and also multiple hypometabolic lesions in the peritoneum, suggesting metastasis, and also in the intra mammary chain, hypometabolic lymph nodes suggest metastasis, and also large amount of pleural effusion in the left thorax. So the patient also diagnosed with stage 4 ovarian cancer. And the other case, in this case also showed a large cystic mass with hypometabolic portion in the abdominal pelvic cavity. So it's really similar with serous ovarian cancer. That can you suggest the other pathological finding of this type of tumor? Yeah, the pathologic finding, it was endometriosis. It's not ovarian cancer. So it is a really similar findings with ovarian cancer, large cystic mass with hypometabolic portion. However, the difference is thick hypometabolic wall surrounding the cystic mass. So yeah, it is not easy differentiating between cystic ovarian cancer and endometriosis, but we need to remember the finding of endometriosis in the FDIS pathology. This is another case. There are cystic mass with a mild hypometabolic solid portion in the pelvic cavity. There is no evidence of distant metastasis in the abdominal cavity and the thoracic cavity. So yeah, maybe you can think this is the probably low-grade ovarian cancer or borderline cancer or cystadenoma. Yeah, the finding was serous cystadenoma. So yeah, it is very understandable. Hypometabolic activity is very depends on the tumor grade. So this type of activity, in the case of this type mild hypometabolic and small solid portion, we can guess it probably low grade or cystadenoma. And next is just a case of response evaluation, the role of response evaluation in the FDIS pathology. So actually it's the case shown in the previous slide. So stage 4 ovarian cancer patient has got surgery and chemotherapy, and the follow-up PET-CT after 4 months. The high permetabolic masses suggest metastasis in both supraclavicular fossa were disappeared. So yeah, in this time the complete metabolic response showed in the FDG-PAS-CD. The other case showing response evaluation using FDG-PAS-CD. This patient also ovarian cancer stage 4. So after surgery and chemotherapy, FDG-PAS-CD was performed, and there are no abnormal hypermetabolic lesions suggesting residual tumor. So also complete metabolic response after therapy. This is another example of a metabolic response seen after neoadjuvant chemotherapy in a 62-year-old woman with advanced inoperable ovarian cancer. So the PET MIP imaging is presented in the multiple FDG uptake lesions in the abdominal pelvic cavity. So in the axial PET-CT showed hypermetabolic lesions in the omentum. After chemotherapy, the peritoneal hypermetabolic lesions decreased 76% of SU max after 3 cycles of neoadjuvant chemotherapy. And so this case showed partial metabolic response after chemotherapy in the FDG-PAS-CD. And the other case, yeah, this is also a little bit interesting for me. Actually, it's our hospital case. So here are several hypermetabolic lesions in pelvic cavity, in adnexa, and in the uterine cavity. So actually, at first we concluded a high possibility of physiologic uptake in the uterus and both ovaries. However, but she has got surgery because of there are medullary lesion in the left ovary, and the pathology finding was surgery-related cell tumor. So it was a little bit confusing with the physiologic uptake of ovaries, but yeah, it was rare sex-cold tumors in the left ovary. So yeah, we need to remember this case evaluating the FDG-PAS-CD in the ovarian lesion. Next case is a stroma ovary. Yeah, as you know, stroma ovary is a teratoma. Teratoma consists of thyroid tissue, so usually this type of tumor has calcification or ossification. So here, yeah, cystic mass with calcification or some ossification with mild hypermetabolism. So it was diagnosed with the stroma ovary, and also in the left ovary lesion. So I thought it could be physiologic uptake, but it was also another tumor, another ovarian tumor, mucinous adenofibroma. So yeah, the patient has several types of tumors in both ovaries. Lastly, I'd like to talk about the pitfalls of FDG-PAS-CT in the evaluating gynecologic malignancies. As you know, the physiologic uptake in the uterus and ovaries are highly related with the menstrual stage. So in the study, they evaluating the relationship between menstrual cycle and FDG uptake in the ovary and uterus. So the black circles indicate a woman with FDG uptake in ovaries, And the white circle indicates a woman without average uptake in ovaries. So the focal average uptake in ovaries are observed in the late follicular to early luteal phases here. And in the uterine endometrium, also the average uptake are observed in the late follicular and early luteal phase, and also the early menstrual period. So if we can get information of the patient, menstrual information of the patient, we can get conclude more effectively the physiologic uptake versus cancer lesions in the uterus and ovaries. So this is the cases of physiologic uptake in the uterus and ovaries. So in a 42-year-old woman during early luteal phase of menstrual cycle, here. So two focal hypermetabolic lesions are demonstrated in pelvic cavity of left spacity. The images, MR images at the same level reveal that focal uptake correspond to the right ovary and endometrium retroverted uterus. And the other case in a 32-year-old woman examined on the second day of menstruation. So focal intense average uptake is present above of urinary bladder. So yeah, it is confined the uterus endometrium. So yeah, it probably physiologic uptake and endometrium. Actually, it is correspond to the early menstrual phase, high uptake. This case is a 43-year-old patient with ovarian cancer history. So there are new lesions in the right ovary. It is a little bit confusing differential diagnosis of ovarian cancer recurrence. However, in the contrast enhanced CT shows the corpus luteal cyst region here. So it could be concluded physiologic uptake of a right ovary. This is also the similar examples of the uterus here, endometrial lining, and functional cyst ovary here. Yeah, actually, this is very high uptake around the cystic lesion in the left ovary, but it was a functional ovarian uptake. However, the other case here, figure B, and the focal uptake in the right ovary of 50-60-year-old woman, it is really similar to physiologic uptake in the ovary, but it was ovarian cancer. So yeah, I'd like to say it is impossible to differentially diagnose between ovarian cancer and physiologic uptake, but based on our knowledge and patient information, we should diagnose ovarian uptake sincerely. So this is the summary. Yeah, average spacity has assumed increasing importance in the management of patients with gynecological cancers. In the cervical cancers, average spacity improve detection of metastatic lesions and also the important role in the detecting recurrent lesions. So it is essential when selecting patient for extensive surgery. In the endometrial cancer, average spacity is useful for the detection of extrauterine disease. It is reported accuracies for preoperative nodal staging, and also it is recommended to exclude unsuspected distant metastasis. Finally, ovarian cancer of this opacity has greatest impact for patient with a suspected relapse with a rising CA12.5. And also it shows promise as a surrogate biomarker to predict chemotherapy response. So yeah, this is the end of today's lecture. Do you have any comments or questions?
So you have shown us a case of maybe circulating cell tumor. Was it? So in that kind of case, what kind of findings should we consider to differentiate with a, to just say this is a physiologic uptake, or whether this can be a tumor? What kind of things should we be in mind?
Yeah, actually, as I told you, it is impossible to absolutely differentially diagnose between physiologic uptake and malignant lesion in uterus and ovary. But just I think it could be very useful if we can patient menstrual information. With the information, we can more easily guess the uptake pattern of the uterine cavity or ovaries. However, but that is not perfect. So I'd like to say we should interpret the uptake of ovary and uterus cautiously.
Is physiologic ovarian uptake usually unilateral, or is it in the mostly seen both sides?
Pardon?
When the physiologic ovarian uptake, is it seen mostly unilaterally, or is it seen in a bilateral?
Oh, it is depends on the patient. Yeah, usually. But in my experience, in the young patient with highly active ovarian function, they usually showed a bilateral ovarian uptake in the functional stage, but some patients showed a unilateral uptake, like this case here. So yeah, I think it's depends on the patient.
Thank you. Would there be any other questions or comments?
Thank you, Dr. Su. Thank you, Dr. Kang, for your nice presentation. I would like to ask about adenomyosis. Is there any clue how do you differentiate between adenomyosis and uterine sarcoma or uterine malignancy?
I'm sorry, I can't hear your voice very low. So please say one more time.
How do you differentiate between adenomyosis and uterine malignancy on FDG-PET?
Adenomyosis, you mean the adenomyosis between malignancy and
yes.
uterus?
Yes, adenomyosis and malignancy in the uterine.
Yeah, okay. Yeah, in this slide, I didn't deal with the adenomyosis, but I think the uptake of adenomyosis is very similar with the leiomyomas in the uterus. So maybe you can in my experiences, adenomyosis in uterus is showed similar patterns with uterine leiomyomas, usually in the epispacity. So, and also the adenomyosis in uterus shows diffuse uptake in the uterus with also increased size in uterus. So at first you can evaluate, you can differentiate diagnosis with FT's uptake, usually mild hypometabolic uptake. And then also in the CT image of FT's fusion passivity, you can find out the enlarged uterus. So it could be point of differential diagnosis for adenomyosis from other uterine malignancy.
Also, adenomyosis, the uptake of adenomyosis is related to menstrual cycles.
Menstrual cycle, I'm not sure because actually menstrual cycle, physiologic uptake by menstrual cycle is highly related to endometrial activation, but adenomyosis or leiomyoma is not confined to endometrium, is part of a myometrium. So I think it is not related to menstrual cycle.
Okay, thank you very much, Dr. Kang.
Thank you.
If there's no more questions or comments, I think we can end up this session now. And thank you very much for the wonderful lecture. Thank you.
Thank you. Bye-bye.